All right, so we'll go ahead and get started. So again, we want to thank the state of Georgia and Georgia Trauma Commission for all the hospitality this week in the context of doing this Georgia Trauma System consultation. And we are going to go over sort of our exit interview findings for over the next few minutes. Want to just mention that the trauma system for the state will get a full report in about 8 weeks, just for some basic fact checking, and then the final report will be due within 10 weeks. So just some overall general trauma system facts. Why we're doing this is injury is a major global public health problem for us. It's the leading cause of death for ages 1 to 44 years, millions of deaths worldwide, the loss of productivity, the loss of the number of potential years of life lost are substantial. Despite all of this and all of our efforts and your efforts, there's very little public focus on this significant public health problem. Some of our challenges as providers is the general public is relatively insensitive and unaware of the magnitude of the problem. They really don't see trauma injury as a public health problem. Millions lack basic training in first aid or initial aid. Political authorities have generally been challenged with their responsibility to provide services. And some of this is just due to the funding constraints that many of our political authorities have. Likewise, I mean, the onus is on us and our medical organizations, which we have also not been as effective in educating the public and advocating to our legislators about the problems associated with injury in our environment. Over the last 50 years, there have been 5 major federal studies looking at the development of trauma systems, including the first in 1966, accidental death and disability, and the most recent, about 5 years ago, the National Trauma Care System, trying to integrate military and civilian systems to achieve 0 preventable deaths. But despite this, there really has been sort of a low impetus for action on behalf of our federal government to take on injury as a public health problem. Despite this, it remains that, this is data from the Centers for Disease Control, that injury is again a significant public health burden, particularly in the first 4 decades of life. You can see that unintentional injury is the #1 cause, but through numerous age strata, you can see that intentional injury and suicide are also significant causes of death and disability in our society. If you look at the age-adjusted mortality for injury across the United States, the areas there that are more darkly shaded tend to have higher age-adjusted mortality for injury, and largely this is due to challenges associated with access to care. So many of those lighter shaded areas you can see are corresponding to major urban environments across the states. But see that there's about 28% of the landmass of the United States that there's actually fairly poor coverage of trauma centers. So that leaves those citizens at risk for worse outcomes from injury. When you look at the state of Georgia is really no different. These are the age-adjusted mortality rates per 100,000 across the state of Georgia. This is the most recent data available from the CDC Whiskers website. So again, you can see the areas that again have been highlighted by the system at the inception of this system consultation. The far west, the northeast, and particularly the south, where there are significant rural environments, have relatively high rates of age-adjusted mortality. When you look at the years of productive life lost, This is the composite years of years of life lost due to injury in 2019. And you can see there's also a significant association of years of life lost in a relatively young, probably a relatively younger population in the metropolitan areas around the state of Georgia. And some of this is likely due to the increase in the burden of violent injury across the nation. Looking at your own stratification of the data from the DPH, again, you can see that particularly in the first, certainly the driving age individuals have a very high rate of mortality from motor vehicle crashes. The chart over here on the right, there was a significant bump due to COVID, and the COVID strata actually was a significant cause of mortality in that 2-year period. But you can see that there are many causes of mortality that are associated with injury that are significant public health threat to the citizens of the state of Georgia. So Georgia has a population of 10 almost 11 million. The land mass of Georgia is 59,500 square miles. There's 159 counties, and 120 of those are rural, so with less than 50,000 population. It's known as the Peach State, and most recently known as the national championship, the Georgia Bulldogs. I'm sure there's plenty of cheering going on the listener end. So looking at trauma system infrastructure across the state, there's 2 main entities, leadership entities in the state, the Department of Health, OEMS&T, and the Georgia Trauma Commission. The Georgia Trauma Commission is served by several clinical and administrative committees. The Georgia Department of Public Health is served by the regional EMS councils, and RTAC councils are subordinate to the regional EMS councils. The trauma system resources for the state of Georgia, there's 324 ambulance agencies, 109 first response agencies, 7 air agencies, each of those with numerous aircraft. There are 4 level 1 adult and 1 level 1 pediatric trauma centers. There's 8 level 2 adult and 2 level 2 pediatric trauma centers, 8 level 3 trauma centers, 9 level 4 trauma centers, and 2 burn centers apportioned across the state. But even with all those trauma centers, there's still a significant area of the state of Georgia that's relatively uncovered and underserved in terms of injury care. So in doing this model and performing this consultation, we look at the trauma system from the inclusive trauma system model. So what is the inclusive trauma system model? Really, the inclusive trauma system model is using all the resources in your state so that you can basically load balance injury across the state, where minor injuries can be taken care of really at any facility. And as injury acuity goes up, those injuries can be triaged to higher levels of care, thereby the thought being that you load balance and minimize the burden of capacity across the system. So again, this concept of an inclusive trauma system, all hospitals will see injured patient, even undesignated hospitals. They must know who to treat and who to transfer. Hospital level and destination should be determined by resource availability and capability, as well as the system need. And those guidelines should be written down, should be codified by the system, and should be uniformly applied across the system. To do this, also system oversight is necessary. Periodic reevaluation of need. And it's also important to have regulations, and not only have regulations, but enforce the regulations that you have. A robust lead agency and leadership is actually paramount to successful to a successful trauma system, because there are difficult decisions that need to be made about really across across the administration of a trauma system. So some of the lessons that we've learned is that in doing these consultations is trauma systems are inherently political. The old adage, the adage we use, if you've seen one trauma system, you've seen one trauma system. There are, and we know that every single trauma system that we evaluate has individual needs and individual challenges. We know that trauma is really not the innate priority for your legislators or the public, and I think that's something that we need to highlight as we move forward. We know there are competing resources or competing priorities for resources, and those challenges have become even more prominent in the last several years across our nation. Progress really is going to require not only active engagement of all the stakeholders here on this call, but there has to be a way to make the trauma system known to the public. The public has to know the public health value and what they're getting for what's the value of having a trauma system to take care of them in their communities. Likewise, it's really incumbent upon trauma system leaders to make sure that your political leaders are engaged. That's where your funding is going to come from to advance your trauma system. So the Georgia trauma system, we're going to now highlight our findings. Again, I want to reiterate that we're going to talk about findings, including strengths, weaknesses, and priority recommendations for the next several minutes. It should be noted that we're going to bring up 14 priority recommendations for the trauma system as a whole, and 8 priority recommendations for the rural environment. But once you get the report back, the report will have the composite list of recommendations, of which there are 89 recommendations for the trauma system as a whole, and 25 recommendations for the rural trauma system, or the rural component of the trauma system. So some of the themes in the last several days that we came across is, again, there's a passion to manage the trauma system in your community, in your state. There's a number of dedicated leaders and a number of dedicated stakeholders. And again, I want to reiterate our thanks to all of you for participating in the meetings over the first 3 days of this week. One quote that we heard at the end of the day on Wednesday, that the system had good bones, and we agree. They're sort of the underpinnings of the system, the passion and the dedication of the stakeholders really cannot be understated here. So there are several things that are very good about this system, and the system has made some iterative improvements since the 2009 visit and consultation by the college. Some of the other themes is, again, the lead agency structure doesn't seem to be effective in meeting the full trauma system need. Obviously, the trauma system is underfunded in spite of the fact that the system has $21 million roughly to manage the trauma system. It's still not enough to manage all of the resource issues across the system. There's significant system challenges, particularly in the rural environment. There's inadequate and inconsistent trauma triage protocols. And despite having significant data repositories, that data is not aggressively leveraged to inform and improve your trauma system. So some of the advantages and assets, the authority to designate facilities and monitor the effectiveness of the trauma system, recruit new facilities, and conduct research on care. The Georgia trauma system funding appropriations address funding for system development, EMS, and trauma systems. So there is funding, which is actually a positive. Many systems across the country don't have the luxury of having the degree of funding that the Georgia State trauma system has. So that is a positive. You just need more. There are active subcommittees with subject matter expertise that are affixed or attached to the Georgia Trauma Commission. The state leadership is definitely dedicated to improving trauma care in the state. Georgia has been one of the most successful states at implementing the Stop the Bleed program and rolling that out across the state. It has really been a model system to do that across the nation. There are a number of passionate EMS providers. The majority of EMS providers are paid by the state. There are resources that exist to facilitate system triage and patient flow with the potential to support statewide load balancing, so the communication center. There's an active statewide quality improvement collaborative. It's just in its nascence now, but if that can be built into its and see fruition, there are lots of potential there. There are requirements now in place for level 1 and 2, level 1, 2, and 3 centers to receive external verification is a significant positive. Numerous rehab facilities with subspecialties, including peds, brain, and spine, exist. The Georgia Trauma Commission actively engages with the legislature. Again, that's a very positive aspect, as that's where your funding is going to come from. You've had 2 NBATS analyses, and the OEMS&T has a dedicated state registrar. The Department of Public Health demonstrates strong resources and has strong resources in injury epidemiology. The Georgia Trauma Commission has resources to assist facilities to develop their trauma performance improvement plans. The Georgia Code has specific protections for confidentiality, discoverability, and peer review proceedings. And you have a very strong emergency management program. So some of the challenges that we have seen over the course of this consultation, there's no single lead agency, and there are no rules or processes on how the 2 lead agencies should work together. So it seems that sometimes confounds and confuses the system. There's no defined accountability for the system's oversight. Again, despite having funding, the funding does not meet the projected need of the system, which is roughly $80 to $100 million to support all the system needs for the state of Georgia. The OEMS&T does not receive appropriate level of funding for full oversight activity. Is underfunded for some of the personnel, some of the activities. There's just not enough resources for the OEMS&T to perform those. There's no state level multidisciplinary advisory group for trauma, and there's a lack of formal and comprehensive stakeholder inclusion and engagement in all of the activities across the system. The trauma system plan is currently almost 8 years old and really doesn't inform the trauma activities of the system. There's lots of expertise across the state. We learned that across the first 3 days of this week. But there's siloed expertise and and resources, particularly in the realm of injury prevention. EMS is not recognized as an essential public service. There's limited ability to accommodate interfacility transfers, and that leads to a lot of challenges, particularly in the rural environment, getting patients to their definitive care facilities. Diversion is a challenge, and diversion is also inconsistently defined. There's no standardized destination protocols or guidelines. Their designation process is delinquent, and it's not aligned with standards. There's minimal collaboration between the GTC and rehab facilities and providers. The RTACs seem to operate really in silos with no uniform operational guidance. Population needs are not routinely assessed across the system to determine the needs of the trauma system needs. Data is used, again, you have data, but it's utilized ineffectively to monitor and evaluate the system. There's a lack of inclusion in rural facilities and hospital outcome review process. The statewide performance improvement plan, a statewide trauma performance improvement plan is not available. And there's no formalized coordination of trauma-specific assets of patient care and the routing between the HCCs and the regional trauma advisory councils. So we'll move on to our priority recommendations. So we have 14 priority recommendations that are really span across the 10 essential trauma system elements, and we'll go through those one by one. So we have 14 for the 14 priority recommendations for the system as a whole, and 8 for the rural component of the system. So with respect to statutory authority, we believe that the system should identify through legislation a single lead agency consistent with national norms for trauma system oversight and development. In lieu of being able to have a single lead agency, you need to develop some sort of structured crosswalk that makes sense to everybody and allows maximal operational capability between the two current structures of the GTC and the OEMS&T, and that needs to be defined in statute. Funding, again, funding is a significant priority and a significant challenge for the state trauma system. Our recommendation is that you actually do a needs assessment. So conduct a new statewide trauma study to determine the current funding needed to sustain and advance the Georgia trauma system and the statewide EMS system across the continuum of care. In addition, we recommend that you obtain a dedicated sufficient funding for the state, for the Georgia trauma system. And again, this is where the implied need to engage the public and engage your legislators to do this. And also in the funding realm, you need to evaluate existing funding to identify opportunities for redistribution of the current funding to develop and particularly to develop and sustain the rural components of your system. So along the theme of leadership, you need to develop a multidisciplinary advisory group. You need to conduct a full trauma stakeholder analysis and utilize this information to structure a multidisciplinary advisory group to ensure that there are member seats for all your regional trauma advisory councils so that you and optimize the representation of the components of the system, including the trauma centers. And I think we would highlight that there needs to be specific inclusion of your rural component, EMS, rehab, your non-designated facilities. Again, we're coming at this in the context of an inclusive trauma system, the military, special populations, particularly geriatrics and pediatrics, and hospital administration. Your trauma system plan is outdated. So once you've sort of gotten a handle on the multidisciplinary and developed the multidisciplinary advisory group, you need to develop an updated trauma system plan, and it needs to be a living document that's revised on a regularly scheduled basis. That we actually have put some recommendations within the text of the report that will give some further clarification on some of the specificity that we think needs to go into this trauma system plan. In addition, we also think you need to come at this truly from an inclusive trauma system model. And this was a recommendation also made during the 2009 consultation. Emergency medical services. Emergency medical services are struggling in your communities, particularly your rural environments. We think that the EMS needs more funding, more resources, and optimally to do that, we would recommend that you declare EMS an essential public service and establish funding mechanisms for its sustainability. For system triage, we recommend you develop standardized regional destination protocols, including appropriate transport to level 4 centers. So this was also a recommendation of the 2009 consultation. We also recommend that you develop a regional medical operation center structure for statewide for basically load balancing, resource monitoring, patient transport transfers to optimize the functionality of the Georgia trauma system. With respect to definitive care, we recommend that you develop performance measures to monitor your designation process, including full compliance with designation criteria. Once a designation application is processed by the lead agency, to make a recommendation that needs to be turned around within 60 days. And you need to have systems in place or a process in place to make sure that every facility that's designated is redesignated every 3 years to maintain quality in your program. With respect to the trauma system registry, we recommend that you develop a collaborative stakeholder data use work group to define the data needs required to evaluate and manage the system. So you need basically subject matter expertise in this area that knows what the data can do and what questions to ask to optimize your system's functionality. System-wide performance improvement. This is also a recommendation from the 2009 consultation, is to develop, implement, and document a system-wide trauma system performance improvement plan. So not a center trauma performance improvement plan. Many of your centers, your trauma centers actually do quite well with center-specific trauma center-specific performance improvement. This is a system-wide performance improvement plan that needs to be maintained at the state level. With respect to disaster preparedness, again, your emergency preparedness is actually done is commendable. But from disaster preparedness, we recommend that you develop early at the lead agency level a multidisciplinary disaster planning group that includes, but not limited to, recommendations from GEMA, DHP, HCCs, and RTAC leadership, and other trauma experts, EMS stakeholders, and military to manage multiple casualty events. Basically, our impetus here is we need to make sure that trauma and emergency management are not operating in silos, so that they're aware of each other's activities and capabilities, and integrate that capability into your RMOC system. So now we'll move on to the rural focus. So with respect to the rural environment, we once again recommend you perform a comprehensive resource and needs assessment, including funding for rural system, emphasizing the rural aspect of EMS and trauma hospitals. A rural capacity needs assessment to identify gaps, including EMS, trauma hospitals, and transfer capabilities, and a plan for recruitment and retention, primarily focused on rural providers, nurses, and EMS. Our second recommendation, priority recommendation, is to ensure the involvement and participation of rural hospitals and EMS within the inclusive statewide system plan. So rural is you have a significant 120 counties of your 159 counties in the state of Georgia that are rural. Rural needs to be part of the big picture, so they need to be engaged in those system level activities. We recommend that you standardize rural trauma care in Georgia, particularly utilizing educational programs. We noted a tremendous amount of heterogeneity in care across the rural environment. We also recommend that you increase the number of rural emergency medicine providers and the resources and to provide capability to manage trauma patients. So not only rural emergency medicine providers, but if they're not formally emergency medicine trained, those providers that are in your rural emergency medicine departments need to be educated on how to manage injured patients. We recommend that you improve scene response times by bolstering existing mutual aid agreements and addressing EMS staff shortages. We also recommend due to the challenges that we have heard about in the last several days with rural care and rural EMS, that you develop an ad hoc process for rescue stops and accelerated transfer for injured patients in rural areas. Another rural recommendation is to provide education and collaboration for rural facilities to achieve proficiency with respect to data entry and data quality, and also to provide rural trauma program managers PI training along with mentorship with support from higher tier facilities. So those are our top, our priority recommendations. Again, we know that this is we know that what we're asking or recommending is going to be a lot of work for the Georgia trauma system. We want to reiterate that we really would suggest that can come at this from the inclusive trauma system perspective, start utilizing, some of those smaller centers within your system. So this is this is a consultative process. There are no true national benchmarks for many of our recommendations. The recommendations we offer are based upon general principles, particularly those of the inclusive trauma system, and experiences that we've had in doing these consultations actually with success across the United States. The solutions are going to be unique, and they're going to be specific to the state of Georgia and the rural environment within Georgia. It's going to require stakeholder engagement, negotiation, and commitment, because this is going to be a long road. Again, the last consultation we did here in Georgia was 14 years ago. There were iterative successes from that consultation, and I suspect that latching onto some of these recommendations, the state of Georgia will make even further iterative process. Despite all of the recommendations we made, we think that Georgia actually has a very good trauma system, and is actually some of the things that the state of Georgia has done have really been examples for the nation in developing trauma systems. So on behalf of the team, the American College of Surgeons Committee on Trauma, we want to again thank the state of Georgia, the Georgia Trauma Commission, for the opportunity to do this consultation. I want to make a point that this program was made possible in part by the state of Georgia funding provided through the Georgia Trauma Care Network Commission. And that is the conclusion of our presentation.
Brian, can you hear me?
Dr. Ashley, you're trying to say something?
I am. Can you hear me?
We can hear you now.
Okay. On behalf of the commission and OEMS&T and DPH and just all the stakeholders in the state, we want to express our gratitude and many thanks for taking, again, a whole week out of your busy schedules to come and help us. I think we were all very impressed with your sincerity and your genuineness and your concentration and focus throughout the whole week. It was obvious that you were well organized and this was not your first rodeo, and that you really had the best interest of Georgia at heart. So we thank you for taking so much time to listen to all our thoughts and gather all the data. I'm already tired from listening to just the priority recommendations. I can't imagine the whole 89. So I think a strong cup of coffee and a little break and then jump into all the recommendations is due. So, but again, thanks again for everyone and for being willing to help us out.
Great. Thank you, Dr. Ashley. We wish you success, particularly with your upcoming legislative session. And we wish you success in improving the trauma system for the state of Georgia, for you, the Georgia Trauma Commission, and also all the stakeholders on the line. So thank you very much.